Let's move on, and I will be presenting a very interesting case which I worked in last 2-3 months. So this was a patient who came to me with a choroidal melanoma with a rhegmatogenous detachment, which itself is a very rare thing. Then I referred the patient to oncologist, and we discussed that I'll fix the retina first, and then she will go ahead and put the plaque. And during the first surgery, I figured that she needed a buckle, but we could not put the buckle because she was having inferior melanoma. So I left the PFO inside the eye. I did a sandwich PFO and silicone oil, and I planned to remove the PFO in 3 weeks because she was undergoing a plaque in the second week. So she came back to me after 3 weeks after getting the plaque removed, and what I see is that there are large choroidals in the periphery and there is a recurrent detachment. So this is a video about the second surgery. And to the best of my surprise, what I learned was the PFO and silicone oil actually got mixed together, and it actually became a denseron, because when I was removing the silicone oil, I noticed that it is actually a single bubble, and I had to use a 20 gauge instrument, which is like, after such a long time, I was using a 20 gauge extrusion to remove the silicone, this denseron. And this is just a brief video showing that I had to struggle to remove the denseron. So I go ahead and remove the further membranes, and you can see the scarring in the periphery. The retina is contracted. I went ahead and did the retinectomy because I figured that it's not settling. And you can see that I'm putting a fresh PFO. I go ahead and do the retinectomy, which was, I would say, did not bleed at all. It was very simple, but still there was a choroidal detachment right here, you can see. And I was wondering that why there is still a choroidal detachment when I have already opened up. Then if it was serious, it should have been drained out. Then out of my curiosity, I went ahead and made a hole in the choroid, and I called it as choroidotomy to see what is going on inside, because this was the same choroidals which I saw in the pre-op. So I wasn't sure that why do we have choroidals. So as soon as I opened the choroid, I'm seeing that there is a denseron underneath. And here you can see that now I had to make this choroidal opening much larger. And now you will be able to see that that is where the denseron is sitting, right at the bottom of this suprachoroidal space, bringing the same point what Coruz was making, that there is, now I have a denseron sitting in the deep in the suprachoroidal space, much posterior, almost reaching to the posterior pole close to the disc. So I tried removing with our soft tape. Uh, I could not remove it. I figured that this is almost the same denseron, so I had to use something really thick and large, wider bore. So I had to use angiocatheter. So I took the angiocatheter. I tried cutting the angiocatheter. I put it in the suprachoroidal space, and I could not reach it. Then I got another angiocatheter, pushed the angiocatheter into the suprachoroidal space, and now you can see that this is the angiocatheter in the suprachoroidal space. And with the help of angiocath, I could remove this denseron completely. And you will see that now the denseron is completely removed. I'm still working on the suprachoroidal space. Now the suprachoroidal space on your right is actually empty, but now the retina on the temporal side seems to be okay. And I went ahead and did the laser, but I was still not sure that this choroidal separation, the retina in that area is not going to settle. And as soon as I put the oil, they all might just push each other and the retina may detach again. So I decided to do circumferential relaxing choroidectomy just to get the sort of a two compartments, so I can have a much more flatter area. I went ahead and did the circumferential choroidectomy almost from top to bottom. Here you can see that I have done the choroidectomy from almost 12 o'clock or 1 o'clock to 4 or 5 o'clock. So after that, once I achieved this two compartments, probably a decent compartmentalization with the choroidal tissue in the middle, I went ahead and injected 5,000 centi-stroke silicone oil under visualization because I wanted to ensure that my both compartments are completely full. Because if I would not have been seeing the filling, I may not have filled up that other compartment completely. So I went ahead and did this filling by looking at the oil and making sure that I'm getting a complete fill. And finally, we ended up closing this complex case. And you will see that this patient came back last week, which was her 2 weeks follow-up. And this surgery was done under 3D. And we were looking at Ingenuity. And this patient comes back after 2 weeks for follow-up. And here you can see that she's already reading to count finger at 3 feet. I have two compartments. One has on your left, which is the nasal part, is having sclera only. And on the right, which is more useful part to us, has only the macula, and her vision seems to be doing good. And you can see that the retinectomy edges are flat. And I'm hoping that this patient will do well. And her tumor itself has regressed completely. Thank you so much. Any thoughts, comments? Gurus?
Great case. You know, the one question is, you know, when you have a melanoma and a detachment, how do you know whether this is not a serous detachment?
Very interesting question. So when I saw this patient, I could see a very typical signs of rhegmatogenous detachment, and there was a break in the infranasal quadrant. And I was sure that this itself was a surprise to me. But by the time we could schedule her for the surgery with me, she had developed extensive PVR and she had developed multiple breaks inferiorly. The things had already gone out of the hand. But considering the scheduling and appointment, it obviously took a much longer time to bring in with me.
Yeah, and the other, you mentioned, you know, the oil and the perfluorine are not a good mix because they do end up being like Denziron. And one of the things, you know, in the US, we do not use Denziron, but in Europe they do. And sometimes removing Denziron is challenging because it can stick to the retina, even inside the eye. And one of the tricks to do is to add perfluorine to Denziron. And what ends up happening, Denziron sticks more to perfluorine than to retina. So you put some perfluorine in and it becomes a lot easier to remove it. But again, as you showed, you know, oil and perfluorine don't mix.
Yeah, and it's surprising that I'm sure that many of the panelists must have used the sandwich, because we used to do quite often back in India as well, silicone oil and PFO. But I have removed latest around 2 to 3 weeks. But this was like almost mixed up together, and I wasn't prepared for this.
Exactly.
Any other thoughts? Anand, Rajendran, sir?
Yeah, actually, a very fascinating surgery. I must say there was some amount of daring there. So I think, yeah, I think having gone the way of sandwich, I mean, personally, I don't really do that a lot. But having done that, I think that innovation of using their angiocath was critical. Otherwise, there was no way that I see that you could have got it out, at least in the time that you did. So I think that is a critical aspect. I just wanted to, just backtrack to another case, the previous case with the suprachoroidal, which Kudus showed us. One technique for removing very posterior suprachoroidal hemorrhage that's been used here is using the Venflon, the vinyl cannula. So you just go through that into the suprachoroidal space and then drain out something which is stubborn and not coming through. But answering to your question here, I think going in that deep, making that choroidectomy was critical. Otherwise, there was no way that Denseron was coming out.
Yeah, Mahesh, sir, you wanted to say something. Thanks, Anand.
Yeah, very interesting case, Dr. J. I was wondering how it went there in the first place.
So that is still a question for me, because I do not know that whether, because the first surgery was, I did not experience any choroidal opening anytime. I'm not sure that during the plaque, the choroid got thinned out or what happened in that area. I'm still not sure that how did it actually go in there.
But the melanoma was not nasal, right? The melanoma was temporal.
Melanoma was inferior. Melanoma was inferior. Okay. Yeah. And I could not see any opening otherwise.
Okay, I have had such situations like of not exactly Denseron, but PFCL or silicon on the suprachoroidal space. One of the techniques which you can try is to do transclerally.
Mhm.
So instead of going posterior, and so you can open the conjunctiva and tag the muscle and use a 20 gauge at the MBR, go inside and twist. So that can make the PFCL or whatever it is, the suprachoroidal space come out. So that way we avoid a posterior choroidectomy. We manage it very elegantly. My only concern is whenever I have done this choroidectomy in trauma patients, ultimately it kind of contracts and the edge kind of lifts up and the oil seems to go underneath. That's the only concern I have. So
Yeah, I'm still
I hope it
hoping.
doesn't happen. Yeah.
I think that something really was useful, which I was very persistent to do in the first surgery, was to make sure her macula remains good, because I knew the periphery is going to redetach. So I went ahead and did the ILM peeling in the first surgery itself to make sure her macula remains good. And I think that's the benefit we are having at 4 months, 4 weeks after the surgery. So I think that was something which I feel that we should be doing more often. Any other comments, thoughts on this? Parveen, madam?
Jay,
You're
very
muted.
nice,
Yeah.
very nice and challenging case. Just wanted to share one of the times when I had to remove Denzeron. So I've used a long disposable 20 gauge needle sometimes when you need to go really too deep, and use it with active suction. So at times it may work, but of course you have to be very careful that you are exactly where you want to be and you don't suck up anything else inadvertently. But sometimes heroic things need to be done like you did them yourself.
Thank you.
Thank you.
Thank you. Yeah. So if